and contractor working with the CFS program at the Centers for Disease Control and Prevention. On behalf of the program, I want to welcome you to today's Chronic Fatigue Syndrome Patient-Centered Outreach and Communication Activity, the PCOCA conference call. Our primary purpose here is to share information with a large number of people who have interest in CFS as part of our regular CFS-ME Outreach and Communication series. Before we get started today, I want to quickly review how the PCOCA calls work. Notification of calls will be sent via email, and information is also posted on the CDC CFS website. Due to the large number of call participants, we are unable to have call lines available in speak mode. Therefore, we will take questions via email using the CFSPCOCACall email system. Note that this email address cannot respond to inquiries. Please note that we will probably not be able to answer all questions. The CDC CF program looks forward to reading all emails and incorporating the questions into agenda items for future PCOCA calls. Our guest presentation today is CFS and Cognitive Function by Dr. Gudrun Lange. First, we'll hear from Dr. Elizabeth Unger, who will give us updates about the CDC's CFS program. After we've heard from both speakers, we will answer questions submitted via email. I will read the questions out loud first, and then our speakers will answer each one. I need to read first the disclaimer. The CDC has no control over who participates on the conference call. Therefore, please exercise discretion on sensitive content and material, as confidentiality during these calls or items submitted via email cannot be guaranteed. Today's call will not be recorded and transcripts will not be made available online. I'd now like to ask Dr. Elizabeth Unger, Chief of the Chronic Viral Diseases Branch at the CDC, to start the call. Welcome, Dr. Unger.
Thank you, Dana, and thank you to all who are participating in this call. This is our fourth call. We implemented these so we could have a regular forum for regular updates on CDC CFS program and to allow CFS experts to present current information on topics of interest to the community. We greatly appreciate the participation of our previous guest experts who have provided commentary and information on issues identifying similar participations for CFS studies, redefining exercise in CFS through reconstruction of aerobic capacity, and on infection and immunity in CFS. We have another great speaker for today. For this call, we have 200 lines available as we've had in the past. These lines are available toll-free for listeners in the U.S. and Canada. We will continue to monitor interest to be sure that there are enough lines available for all who would like to call in, and we'll make modifications to the call format as needed. I would now like to give you an update on some of the CDC's activities. In December 2013, I attended the second International Symposium for CFS-ME and participated in the opening ceremony of the National Center for Neuroimmunology and Emerging Diseases at Griffith University, Gold Coast, Australia. It was wonderful to learn from the international experts and to share information about CDC's program. Another meeting that CDC will be participating in is the upcoming biannual meeting of the International Association for Chronic Fatigue Syndrome, Myalgic Encephalomyelitis, being held March 20th to 23rd in San Francisco, California. This meeting is entitled Translating Science into Clinical Care. CDC awarded a contract to the IACFS-ME to support this meeting, and I was very happy to have served on the planning committee with President Fred Friedberg. 5 CDC personnel will be attending the meeting, presenting 3 posters, 2 oral presentations, and sharing. We're all looking forward to this opportunity to meet with the international community of clinicians, scientists, patients, and advocates. In addition, Dr. Jose Montoya of Stanford University has organized a pre-meeting continuing medical education course for the day before this conference. The course is entitled 2014 Stanford Myalgic Encephalomyelitis Chronic Fatigue Syndrome Symposium, Advances in Clinical Care and Translational Research, and is being held at the La Ka-Shing Center for Learning and Knowledge at Stanford. I've been asked to give a talk entitled Epidemiology of ME/CFS, What Have We Learned? We have initiated a new collaboration with the CDC Behavioral Risk Factor Surveillance System, known as BRFSS, to include 2 questionnaires in the state-added part of the survey to address CFS prevalence. To explain why this is an exciting initiative, I need to give you a little background about BRFSS. This is the largest telephone survey in the world, and in 2013 marked the 30th anniversary of the survey. I'm now going to quote from their frequently asked questions found at cdc.gov/BRFSS. Quote, "It is the nation's premier system of health-related telephone surveys that collect state data about U.S. residents regarding their health-related risk behaviors, chronic health conditions, and use of preventive services." End quote. The main survey collects data in all 50 states as well as the District of Columbia and 3 U.S. territories. Other modules on specific topics are optional. States can also choose to include additional questions to address health concerns of particular interest to their states. Decisions about what questions to include in the survey are made by the BRFSS state coordinators with input from their state authority and CDC. While there is limited space for additional questions, they are constantly looking for more topics that may accommodate other CDC programs' needs. Proposals are submitted to the BRFSS Questionnaire Planning Committee and presented at the BRFSS conference for discussion. In the past, the survey has measured self-reported prevalence of other chronic conditions, including cardiovascular diseases, diabetes, arthritis, asthma, and hypertension. Our epidemiology group developed a proposal to include CFS questions in the 2014 BRFSS survey and presented this at the 2013 BRFSS conference. This was the first time that CFS was introduced to this group, and it allowed state public health leaders to learn about the public health importance of CFS. As a result of this initiative, 40 states are interested in including 2 CFS questions. They are, quote, "Have you ever been told by a doctor or other health professional that you have chronic fatigue syndrome, CFS, or myalgic encephalomyelitis, ME?" End quote. And if the answer is yes, quote, "Do you still have CFS or ME?" End quote. Answer to these questions will provide a cost-effective way to monitor CFS prevalence based on self-reported diagnosis, and to study CFS in relation to other BRFSS topics such as nutrition, healthcare access, quality of life, physical activity, and health status. This will also provide state-specific information on the burden of CFS to support decisions about developing state public health plans addressing CFS. It will be a while until we know for sure if the states were able to initiate the CFS questions this year, but it is a promising start towards moving CFS into the mainstream of public health. The multi-site clinical assessment of CFS continues to be a major focus of our group. This study has been introduced on this call in the past, and the study has been described and discussed in previous CFS advisory committee meetings. As a quick review, the study is designed to collect standardized information on the major illness domains of CFS from patients in the clinical practices of clinicians with particular expertise in CFS. This allows us to capitalize on the clinical expertise of these physicians. Rather than requiring a specific case definition for enrollment, the clinicians determine which patients meet their clinical criteria for ME/CFS or post-infective fatigue. We are greatly indebted to these 7 clinicians and even more to their patients who have been so willing to participate. A synopsis of the study design can be found on the CDC CFS webpage under the Resources section, CFS. On January 27th of this year, I presented the methodology of the study to the Institute of Medicine Committee, considering the diagnostic criteria for myalgic encephalomyelitis chronic fatigue syndrome. We've also provided the questionnaires used in the Stage 1 study to the committee and will provide tables and analyses as they are requested by that committee. Stage 2 of our multi-site clinical assessment of CFS is well underway. As a reminder, Stage 2 includes 3 types of protocols. The first is a follow-up of patients enrolled in the Stage 1 protocol, as well as enrollment of healthy controls, as well as patients ill with other conditions that may resemble CFS, such as fibromyalgia, chronic Lyme disease, chronic hepatitis, or congestive heart failure. These patients will serve as an additional comparison group. In addition, study participants are asked to collect morning saliva samples at home before their clinic visit so that we can determine a waking cortisol response. At the clinic visit, blood samples will also be collected for archiving whole blood DNA and RNA. As of February 10th, we have 75% completion of CFS follow-up and 32% completion of the 2 comparison groups. Saliva and blood sample collection is working well, and so far we've received samples on about 50% of the participants who have completed their Stage 2 visits. The second protocol of Stage 2 is to enroll pediatric and adolescent patients. We use the same kinds of questionnaires as in the adult Stage 1 protocol, but modified to make them age appropriate. This protocol was initiated after receiving all IRB approvals in September 2003. The targeted enrollment is 140, and as of February 10th, the completion rate is about 25%. The third protocol is a combined cognition and exercise protocol. We have not yet initiated this study, but anticipate that it will begin soon as it has been approved by 2 local IRBs and only 1 is still pending. Dr. Lange, our guest speaker today, was instrumental in designing the cognition portion of this protocol, and she has conducted a pilot test of this section. An important part of the pilot was to be sure that the patients could complete the online version of the test on the days following the clinic visit. The computer-administered modules were developed by Cogstate. At the time of the last PCOCACall, contracts for Stage 3 of our study had just been awarded. On November 7th and 8th, 2013, we held a meeting at CDC with our clinicians and study coordinators to review progress and make plans for continuing and extending our work. As before, it was a wonderful opportunity for those involved in the study to communicate with each other and exchange ideas. Stage 3's plan to continue follow-up as in Stage 2, but to enroll homebound CFS patients and newly diagnosed patients. There was a lot of discussion about how to define homebound, as the clinicians indicated that the only activity out of the home that some of their patients have is to come to their clinic. Some clinicians felt that visits to patients' homes could be accommodated, and we agreed that it may be helpful to stratify homebound based on the extent of limitations experienced by the patient. For example, the most severe category would be those who are unable to do self-care and are bedridden all day, and the least severe would be those who are able to do limited self-care and are recumbent most of the day, leaving home only for brief periods such as for medical or religious reasons. For newly diagnosed patients, most felt that it would be feasible to enroll patients within 1 to 2 years of their symptom onset. Stage 3 also includes collection of blood samples for serum and plasma archives, as well as to determine measures of natural killer cell number and function. Research studies have identified that natural killer cell function is impaired in CFS. The research tests all use samples that are tested within hours of collection. In our multi-site study, implementation will require shipping samples and at least a 24-hour delay between sample collection and processing. Because of these requirements, we are developing a pilot project to optimize sample collection and processing for NK cell testing prior to implementing the protocol for our study. In the previous PCOCACall, I mentioned that we had developed a new section on pediatric adolescent CFS for our webpage. This was developed after meeting with patient advocacy groups that have had experience with CFS in children and adolescents. We spoke with the New Jersey CFS Association, the Massachusetts CFS ME Association, Speak Up ME Group, and the Wisconsin CFS ME Association, as well as a professional educator who is addressing CFS in middle schools. Content was also reviewed by outside clinical experts in pediatric CFS suggested by the advocacy groups. The new section was reviewed by CDC and revisions were requested. Requested changes all related to the goal of improved clarity and compliance with CDC web policy, and it is once again waiting final approval. We now anticipate that it may be posted in May of 2014. The Medscape Continuing Medical Education course entitled A Case-Based Approach to Chronic Fatigue Syndrome that was sponsored by CDC is still active. It is hosted on the Medscape webpage, and Medscape is responsible for publicity. The course is free, and CDC provides a link to its CFS website. As of the end of January 2014, there were 11,846 learners, including 4,094 primary care practitioners and 2,128 nurses or nurse practitioners. And 1,189 of these were issued CME credits. The certification for continuing medical education ends in May 2014. At that time, Medscape will provide data on the pre- and post-test questions so that we can evaluate how well learning objectives were met. CDC's 2 free online CMS courses are still available through the CFS webpage. The course on diagnosis and management of CFS is accredited for continuing medical education units, continuing nursing education units, continuing educational units, and continuing health education units. As of November 2013, 675 credits have been issued. The Sleep Problems in CFS is accredited for continuing medical education units, continuing nursing education, and continuing education units. As of November 2013, 422 credits have been issued. At this point, I would like to turn the call over to Dana Brimmer so that she can introduce our speaker.
Thanks, Dr. Unger. It's a pleasure today to introduce Dr. Gudrun Lange. Dr. Lange received her doctoral degree in psychology in 1994 from the City University of New York and completed postdoctoral training in neuropsychology at Memorial Sloan Kettering Medical Center in New York City and the University of Medicine and Dentistry, New Jersey Medical School. During her training, she worked with cancer patients who had treatment-related cognitive difficulties and with Gulf War veterans with cognitive difficulties. Throughout her career, she has worked to understand the nature and underpinnings of subtle or mild cognitive dysfunction in patients with acquired brain injuries this includes patients with cancer and traumatic brain injury, fibromyalgia, and ME/CFS. Dr. Lange continues her private neuropsychology practice, where she focuses on assessing and identifying subtle cognitive disorders and works as a research consultant for the Pain and Fatigue Study Center at Mount Sinai Beth Israel Medical Center in New York City. She remains a professor of physical medicine and rehabilitation at Rutgers University in New Jersey. She will be presenting today on CFS and cognitive function. Welcome, Dr. Lange.
Thank you very much, Dana. Thank you very much for inviting me to talk to you today about cognitive function in myalgic encephalomyelitis, also referred to as chronic fatigue syndrome. I will refer to the illness as ME/CFS throughout my talk. Over the past 17 years, I have assessed hundreds of patients with ME/CFS neuropsychologically, and in parallel have also worked as a researcher to understand how dysregulation found in a number of body systems affect the brain and cognitive function in patients with ME/CFS. I welcome the opportunity to talk to you today because I will have a chance to answer a question many of my patients ask, and this is the question. I spend a lot of time undergoing a neuropsychological evaluation because I'm just not right. Not like I used to be able to think. But the neuropsychologist said everything is in the average range and nothing is wrong with me. The majority of individuals with ME/CFS have cognitive difficulties. This statement is supported by a vast body of neuropsychological and imaging research with individuals with ME/CFS. The importance of this symptom is further underlined as it is recognized as an important illness symptom by each one of the multitude of currently existing case definitions. Finally, the measurement of cognitive symptoms is the objective criterion for disability claims, further underlining its importance. A patient with ME/CFS is not considered disabled simply because of having the symptoms consistent with a case definition of ME/CFS, they have to show the, and I quote, existence of a medically determinable impairment, that is, one that can be shown by medical evidence consisting of medical signs, symptoms, and laboratory findings. At this point, we do not have any laboratory markers yet that could serve that purpose. So therefore, it is very important for you to understand what is meant by the term cognitive dysfunction or difficulties or impairment and how that is measured. You need to be a well-informed consumer or patient. That's what you really need to be. So let me first give you a little general primer about what cognitive difficulties are, how they come about, and how severity of cognitive dysfunction is evaluated. Then we'll go on to discuss cognitive dysfunction within the context of ME/CFS. What are the most common deficits and how do they affect other areas of cognition? Remember, the brain does not consist of separate little areas, each doing its thing, but is one organ with several areas, many of them working in concert, so we have to be cognizant of that and sensitive to it. Then I'll tell you about how cognitive dysfunction in ME/CFS should be evaluated comprehensively. I'll also provide you with some questions you should ask your neuropsychologist before and after testing, so you can approach your assessment as an educated patient. Finally, I'll give you a few suggestions about how to help yourself cognitively if you are an ME/CFS patient with cognitive problems. So let's start with the question, what are cognitive difficulties? How do they come about? There are two basic ways an individual can suffer from cognitive dysfunction. Cognitive symptoms can arise genetically or congenitally. That means they are present at birth and their effect is almost always permanent. Secondly, the cognitive dysfunction can be acquired after birth during an individual's lifetime. They can be brought on by insults or injuries to the brain as we live our lives. Those events can include stroke, traumatic brain injury, brain tumors, infections, poisoning, substance abuse, and also hepatitis, for instance. Acquired brain injury, also called ABI, can result in temporary but also permanent chronic changes affecting cognition, as well as physical and emotional function. So this was a brief overview of how an ABI can come to pass in general. Now, how is severity of cognitive impairment determined? The nature of cognitive difficulties, or ABIs, can range in severity from mild, also called subtle, to severe and can be either stable or progressive. Here are some examples. One example for a severe progressive situation would be some type of dementia, where overall intellectual ability deteriorates over time in concert with memory functions. An example for a moderate, stable situation that might even be remediable could be aphasia, which is the ability to speak and or understand words after a left-sided stroke. Finally, an example for mild or subtle cognitive difficulties could be mild traumatic brain injury suffered because of a motor vehicle accident or perhaps by exposure to environmental toxins or by infections, as may be the case with ME/CFS. For purposes of documentation and treatment, severity is determined in two ways. First, via subjective determination of loss of cognitive and behavioral function based on the patient's or family's report and the examiner's examination, observation, and interpretation. This is called a subjective assessment. However, while subjective perception of degree of loss of cognitive function is an important factor, objective measurement is the preferred way to document cognitive dysfunction and necessary for most ME/CFS patients. To do that, you need to undergo neurological testing. The scores you are achieving on neuropsychological testing are then compared with sets of standardized norms that should exist for any test you take. Statistics are applied, and the neuropsychologist is then able to determine whether your performance falls within the, quote, normal range compared to standardized norms, or whether it falls outside the normal range, good or bad. Degree of deviation from the normal or middle-of-the-road score then determines how well or poorly you performed on a given test. The larger your score deviates negatively from the middle-of-the-road score, the more severely affected is the particular cognitive skill that was evaluated. When your score falls at a point where only 2.5% or less of all the individuals in the normative sample scored, your performance on the test you took is considered to be absolutely impaired. A neuropsychological battery does not consist of only one test, though, but several tests and subtests. In order to determine the severity of cognitive dysfunction as a whole, the neuropsychologist has to look at the entire profile of scores and what ranges they're in. If you have several scores in the absolutely impaired range, cognitive dysfunction is usually considered to be severe. Having said that, this scenario is not often the case in ME/CFS. In fact, ME/CFS patients score often in the normal range on tasks that do not have a time component where they can take as much time as they need, such as measures that assess formally learned knowledge or probe into an individual's ability to provide verbal or visual concepts. ME/CFS patients generally achieve at least middle-of-the-road scores on these types of tests. However, when tasks have to be done fast or multiple pieces of information need to be dealt with right then and there, ME/CFS patients are generally not in the middle-of-the-road portion of scores. Many of my patients struggle significantly to do these types of tasks and achieve poor scores. So sometimes it is possible that a neuropsychologist looks only at summary scores of certain tests in a battery without considering the differences between scores on subcomponents. Another issue can arise if the examiner only considers number of correct responses on untimed tests or tasks, which I've just told you ME/CFS patients do generally well in. Research has now established, and we published a recent paper on that number of correct responses is not an optimal outcome variable for our patient population, but we have to consider how long it took an ME/CFS patient to perform well. The person more than likely will have been slower than an average middle-of-the-road person, unless the information elicited was simple and well-practiced. Then, as I said earlier, they score pretty much in the normal range. But I'll talk about that a little later again. To illustrate how cognitive dysfunction in ME/CFS can manifest itself in everyday life, let me give you some examples from my practice that may sound familiar to some of you. Pam, a 38-year-old wife and mother of 5- and 8-year-old girls, used to be a marketing executive for a large advertising agency. In her spare time, she enjoyed spending time with her husband and kids at soccer and softball practice. She also loved to cook. Pam came down with the flu about 1 year ago and never fully recovered. First, she gave up participating in family events and curtailing social engagements to sleep and rest on the weekends to be ready for work on Mondays. However, at work, she experienced significant difficulties preparing and giving presentations, a skill she was well known for. Pam was not able to convert her job into a part-time position and stopped working about 4 months ago. She has a hard time doing household chores. Even taking a shower is a major undertaking. Her husband is supportive of her, but the financial and emotional put on the family are beginning to show. Pam is scared about what will become of her and her family. He right now feels useless and like a burden to everybody. Robert is a 58-year-old international lawyer. He used to be stationed in London, but moved back to New York to be closer to family. He still perceives himself as a successful lawyer. Due to the international aspects of his business, he gets to the office by 7 a.m. However, by 11 a.m., he is so fatigued that he needs to take a nap under his desk or in the bathroom. He prefers phone conferences to face-to-face meetings now because he can make notes for himself. Although this has started to prove difficult as well, as his notes have become a lot spottier over the recent past. Robert used to deal with a number of cases at a time. Now, he is looking for excuses to avoid that. His boss has noticed that his billable hours have gone down, and he is afraid he'll lose his job. His social life has deteriorated as well. He got a cat to try and deal with his increasing feelings of loneliness. Finally, Marita is a 45-year-old homemaker. She has a husband and a dog, but no children. Marita has a hard time going shopping. Parking on the supermarket parking lot is the first challenge. He tries to park at a landmark, either a lamp, flagpole, or other prominent feature on the parking lot, like a garbage bin. First, she tried to remember the route she took to walk into the supermarket, but at this point, she just sketches the way she walks into the supermarket onto the palm of her hand, as she got lost finding her car several times. Parking garages are even worse for her. Once she gets into the supermarket, she concentrates on her shopping list and avoids her tendency to walk around and browse. Marita used to enjoy comparison shopping, but now she knows that if she does not complete her shopping quickly, she'll run out of energy and will get back to her car with only some of the items needed. Once she gets home, her dog is waiting for her to go out. Luckily, her husband has built a fence in the backyard so that she can just let him go out and does not have to walk with him. Even 2 blocks are sometimes too much. Now, I can already hear some of our listeners who may have ME/CFS say, "Yep, that's me. I've got that brain fog. I do feel like I have my head in a bag of cotton balls. Sometimes I swear I feel like I'm losing my mind." And some patients say that they feel like having a brain of an 80-year-old person at the age of 36. Some of my ME/CFS patients are concerned that they are dementing, permanently losing their intellectual capacity. I'm happy to say that this is not the case for patients with ME/CFS unless other neurologic conditions are present that may have that effect on the brain. So I have said that cognitive problems in ME/CFS are rarely classified as absolute and severe impairments. So what are they then, and how can going to a neuropsychologist help you? Briefly, over the past 20 years or so, many studies have looked at the integrity of the brain in ME/CFS. Over this time period, the most consistent cognitive findings point to poor attention, concentration, and working memory, and impaired information processing speed, especially when the information that needs to be processed is complex or multifaceted. Executive function, which is briefly put the ability to organize and sequence actions or thoughts, and learning of new information are also affected in some cases. When I say learning is affected, I am talking about how ME/CFS patients encode, or another word for that is absorb the information. It is often the case that they do not use optimal ways to learn, even though they may have done so in the past. But now, once they're sick, they tend to use a more random approach, which results in poor information recall. This effect is a direct result of poor attention, concentration, working memory, and information processing. Why? Because all of these functions can and will affect downstream memory, motor, and executive function. They will slow the system down so you're only able to work with or remember partial information. One of the most common complaints from my patients is that one. I asked for directions at the gas station. I understood the very first part, but from then on, I just nodded because it was just a blur of words coming at me, and I didn't remember a thing. This is the everyday event that occurs when what I just talked about happens to you, the patient. And it does, as imaging research has shown us, it's a real phenomenon, not imagined. Excuse me. The neuropsychological findings I talked about have been supported by a number of static and dynamic imaging studies, such as MRIs, PETs, and functional MRIs. Summarizing the data, I can say that in general, ME/CFS patients try hard to complete cognitive tasks. When tasks aren't timed, they perform as accurately as healthy individuals, yet a lot slower. Thus, patients with ME/CFS are limited by slowed information processing. We know that from neuropsychological and imaging research as well as clinical observations. The research findings are important because they inform us in clinical practice. Here is an important example. When the task is easy and serial and could even be timed, but no multitasking is required, no problems generally arise for ME/CFS patients. However, when the task is getting more complex and several steps occur in fast sequence or at the same time, brains of ME/CFS patients begin to look different than the ones of controls. In fact, researchers documented that when the load, which means the information going in, the amount of information going in, becomes very challenging, as in the example above where the person asks for directions, brains of the ME/CFS group have smaller activations and at times no activation at all. These findings suggest that the individual is overwhelmed and shuts down cognitive function, cannot absorb the information anymore. Does that sound familiar? Doesn't that sound like the example I talked about with the gas station above? What does all this mean for the neuropsychologist? He has to include tasks in his assessment battery to challenge complex information processing and multitasking, as well as tasks that show middle-of-the-road cognitive ability, such as a person's ability to remember well-learned information or word knowledge, language ability, and basic visual, spatial, and motor skills. This needs to be done to be able to contrast and compare the overall profile findings. Now, one last important topic that we have addressed in our research is the following. Many of you may have heard this. Oh, well, this patient is just not trying hard enough. She looks fine. Functional MRI data from our lab have shown that, in general, ME/CFS patients do not amplify their cognitive problems, but in fact, they have cognitive problems that may not be picked up by non-sensitive neuropsychological measures or unknowledgeable practitioners that do not interpret test results carefully. So now you have completed your testing, and the neuropsychologist has to score and interpret the data, your cognitive profile. In order to do that, she has to form some informed hypotheses about which cognitive functions may be better or worse than others in your case. This approach to cognitive assessment is not unique to ME/CFS. Just like physicians, many neuropsychologists specialize in specific brain conditions. For instance, if I don't generally work with stroke patients, and I don't, but I need to assess one cognitively that suffers from aphasia, I would consult the literature to brush up on the most prominent areas of poor function for this condition and what cutting-edge measurement tools are generally used to evaluate that at this point in time. This would be my guide to develop the assessment battery for my aphasia patient. So you will need to find out whether your neuropsychologist has a rudimentary familiarity with the literature on cognitive function and ME/CFS. They just have to know about the illness they are assessing, and this is where you come in, the patient. You have to educate your provider. As I said earlier in this talk, overall cognitive dysfunction in ME/CFS is considered to be subtle or mild, which does not mean that the consequences experienced by you, the patient, are not severe. In my experience, I find scores that are consistent with absolute impairment on any given task only in the most severe cases of ME/CFS. However, I found relative impairment in not all but many of my ME/CFS patients. Now, what does relative impairment mean? Here's an example to illustrate what I mean. Only if all cognitive domains work at the same level in unison can an individual achieve optimal overall cognitive function, can be at the top of his or her game. So how could a person function optimally if her information processing speed and working memory are in the, say, low average range, while her ability to comprehend language and use verbal and visual concepts successfully is in the above average to superior range? There is a discrepancy. Even though she has no problems comprehending what is said to her, if it is said quickly, she'll be at a disadvantage because she cannot process the incoming information fast enough and keep it online to respond appropriately. She's not on the top of her game. So as I said earlier, it is important to evaluate and interpret the differences between scores within the context of overall intellectual function. As I said in the beginning, the brain is a unified organ with all parts working in unison for optimal performance. However, some parts may not be working as well as others and may impact on function of the entire brain, which can have severe consequences for the patient. For many disability claims, an ME/CFS patient has to show that symptoms are, quote-unquote, severe enough to result in, quote-unquote, regular, predictable, or sustained limitations of even sedentary or light activities. That is often the case in my experience. I hope at this point I haven't confused you too much with technical details. Now that you maybe are a more knowledgeable consumer of neuropsychological services, I'm going to provide you with a brief list of questions you should ask the neuropsychologist before you go for testing and after you completed testing. First, don't be shy to ask the clinician how many ME/CFS patients he or she has assessed previously. If they have not seen any ME/CFS patients, provide them with a brief review paper on cognitive function in ME/CFS. May not look like it's going to be welcome, but you're going to have to try. Second, if they have seen ME/CFS patients previously, ask which cognitive domains they feel are important to assess and what areas they put emphasis on. Quiz your neuropsychologist a little bit. Don't be rushed through the intake onto the assessment just to get finished. If a technician performs the evaluation, ask to speak to the supervising neuropsychologist. He or she should be the one responsible to interpret the data and should be able to answer all of your questions. Third, provide the examiner with remarks during testing like, "This is really hard for me," or "I feel like I cannot hang on to the information you just gave me," or ask them to repeat instructions. The examiner should make note of these observations as they should be considered when test results are interpreted. Finally, neuropsychologists will provide a feedback session after writing up the neuropsychological report. Take advantage of it. Don't be shy to ask the neuropsychologist about how she arrived at her results in each section of cognition assessed. If you're puzzled by the results, don't hesitate to show the report to another neuropsychologist familiar with ME/CFS for a second opinion. Isn't that what you do with doctors sometimes? Finally, I'll give you a few suggestions about how to help yourself if you are a patient with cognitive problems. There are two general approaches in cognitive rehabilitation that help patients cope with chronic cognitive deficits. First, recovery or remediation of cognitive function that focuses on directly retraining cognitive processes that have been affected by ABI, acquired brain injury, such as undergoing attention training. Nowadays, there are a couple of video programs out there that use this approach. Second, developing and learning compensatory strategies that focus on developing compensatory skills to enhance performance on everyday tasks, such as going shopping. Brief review of the large and diverse literature on this topic suggests that patients with ME/CFS will more likely benefit from developing and learning compensatory strategies, as it will build on their strengths and help them gain control over certain aspects of their lives. While I know it is difficult to overcome or even accept the loss or deterioration of important cognitive skills that are so very closely intertwined with quality of life and professional success, it is helpful to be able to reinterpret these losses in a positive sense. This will allow you to take greater charge of your life and develop strategies to perform everyday tasks in a different manner. So here are some suggestions for what is called cognitive rehabilitation. Absorbing information, as in the example above, where my patient asked for driving instructions. Instead of trying to catch up, inform your conversation partner right from the start that you would appreciate it if she could speak slowly and to allow you to reply to her once she finishes her point. It is a good practice to summarize and repeat what the person just said so you can encode it better. Note-taking. Note-taking while listening to another person is very difficult for patients with ME/CFS. If possible, listen. Don't write while you listen. Try to get the major point and jot it down. Driving a car. When driving a car, keep distractions to a minimum. Some of my patients drove to a completely different destination than the one they were aiming for while listening to the radio. Cell phones and other gadgets that ring, ping, blink, or rattle. Keep gadgets to a minimum and turn them off completely when engaged in specific tasks. Some of my patients have begun to appreciate that they allow themselves to fully engage in a person's conversation without electronic interruption. Reading books and newspapers. Try to read one paragraph at a time, then summarize for yourself what it said. Perhaps that will eliminate reading the same paragraph over and over and over again, as many of my patients tell me. Cooking. Cooking is a more complex task than many people think because it requires a lot of sequencing. If you plan to use a cookbook, it definitely classifies as a prime example for multitasking. So instead of collecting all ingredients as you go while reading the cookbook, assemble and organize everything before you start. This will eliminate some frustration and prevent feverish searches for ingredients resulting in scorched food. Time management. People with ME/CFS have only so much energy available to do what they need to do. Make a weekly plan of things that need to be done urgently, in red, moderately urgently, write that in yellow, and not urgently at all, write this in green. Don't forget to also plan for some fun activities. Bill paying. Use the same strategy as the one for time management I just told you about. Just use colored folders instead. Learn to say no. You may have been the person that was able to do a million things at the same time cheerfully, but maybe not so much anymore. Say no if someone wants you to do something in an impromptu fashion and instead suggest a different time or place. Inform people about times during the day that you will accept and respond to phone calls or emails. Trust me, people will get used to this, and they may even approach some structure within their worlds of continuous social outreach and communication favorably. Be proactive in organizing your life using the resources and strategies available to you now, not before you became ill. I hope what I said today was I'd like to thank everybody for their time and attention to listen to me. Thanks. Bye-bye.
Thank you, Dr. Lange. We will now move on to questions for both of our speakers. Since we did get started a little bit late today, we will go till about 5 minutes after 4, and I think we have enough time for at least 2 questions for the speakers. First, Dr. Lange, what percentage of your ME/CFS patients are severely ill or housebound, and can the tests be administered at home to people who are housebound?
Okay. To your the first part of your question, severely ill, I don't classify patients as severely ill only when they are disabled or on disability. So the patients that I see, I would say about 50% of them would qualify as severely ill because they have extreme difficulties from a cognitive perspective to navigate the world. Even if people are severely ill and spend a lot of time at home or even in bed, they usually can come to my office. I have some patients that are not able to come because they're bedbound. And that addresses the second half of your question. Can patients be tested when they are bedbound? Yes, they can. It would require an effort on the part of the neuropsychologist, but most of our tools are transportable. So from that perspective, it should not be impossible to test a person at their home. The other issue is whether the person is able to sustain at least an hour or 2 of continuous testing. So there it may be touch and go. But I think at least it would be possible to provide a screening at the bedside.
Thank you. And a second question for Dr. Lange, and some of this was covered in your excellent talk today, but we have a question that there's a sentiment that neuropsychologists do neuropsychology exams only for diagnosing psychiatric disorders. However, this person has had a neuropsych exam to assess cognitive function CFS, and she's wondering if you could please comment how many doctors think that CFS is purely a psychiatric disorder versus using the neuropsych testing to help patients with CFS.
Well, as you said, I kind of touched upon that in my talk. Unfortunately, I think neuropsychologists in general could benefit from more education about ME/CFS. It is not a psychiatric disorder. It is, in my mind, it is a disorder that where people suffer from acquired brain injury, and it should be treated as such. So what neuropsychologists should do is to look for the strengths and weaknesses of people that have ME/CFS. They do have to take psychiatric issues into account in the interpretation of test results, but the prime purpose for neuropsychological evaluation is to gain a cognitive profile of the patient.
Great, thank you. I have one more question for Dr. Lange, and then we'll move on to Dr. Unger. Dr. Lange, what biomarkers should be combined with your findings to help define subgroups of patients?
Well, that's a question a lot of people are researching. I think it would be great if we could have as many biomarkers as possible to see which one is the best. I'm not a physiologist or an immunologist, so I cannot really talk about specific ones. But I know that in our lab, we have tried to combine cognitive function with spinal fluid markers, biomarkers that are inherent in spinal fluid, and we're continuing that work. So that is one avenue I would love to continue to.
Thank you very much. And now, Dr. Unger, we have a few questions for you. The first actually is a clarification. Could you please clarify if it was 14 or 40 states who are participating in the BRFS risk
Yes, that was 14 states expressed their interest in participating.
Thank you. And here is a question for you. I have heard that post-exertional collapse or malaise occurs in other illnesses. Can you please explain which illnesses and how it may be defined and what is known about any qualitative differences between post-exertional malaise in CFS compared to other illnesses?
That's a very interesting and important question that I've heard asked in many different ways by many people. Post-exertional collapse is another term that's used. And there's no simple answer to that because we don't have good measures of post-exertional malaise, and clinicians and researchers don't ask patients about this problem in the same way. What we do know is that nearly all patients with illnesses that are associated with fatigue, such as autoimmune diseases, viral infection, cardiac diseases, anemia, and many others, experience a worsening of their symptoms after exercise or exertion. We also know that this symptom is experienced by nearly all ME/CFS patients and is very characteristic of ME/CFS. Post-exertional relapse or malaise is commonly one of the most disabling symptoms experienced by ME/CFS patients and is the reason why exercise requires very careful introduction and monitoring, as described by Dr. Klimas and Connie Saul in one of our previous PCOCA calls. The extended duration of this worsening or post-exertional malaise is what appears to be more characteristic of ME/CFS. However, patients with chronic Lyme disease, fibromyalgia, and HIV all have described post-exertional malaise or collapse using words very similar to those used by ME/CFS patients.
Thank you. And here's another question for Dr. Unger. On the last PCOCA call in September 2013, Dr. Lipton reported finding polyclonal B-cell activation in ME/CFS patients in his current study as well as a past study. How many of the 471 patients in the CDC study have this immune abnormality? And do the 7 clinicians in the clinical trial study test for it? And if not, can it be added?
Dr. Lipton's presentation gave us all a lot of interesting information to consider. It's important to keep in mind that the normal immune response should be polyclonal. Polyclonal B-cell activation is a description that could be interpreted in a variety of ways. I verified with Dr. Lipton that he was referring to his findings that CFS patients had antibodies to a wide range of proteins, including some not found in infectious agents. There's really no specific test to look for polyclonal B-cell activation. It has been suggested that the antibody responses in CFS patients could be different from normal controls, explaining antibodies to a wide variety of viral proteins and potential autoantibodies. The clinics in our study use immune function tests that they tailor to their individual patients. So in summary, this issue has not been addressed systematically.
Thank you very much, Dr. Unger. And that brings us to a close for our call today. We want to express many thanks to our speaker, Dr. Gudrun Lange, for taking the time to be with us today, and to our participants for your time and interest. As a reminder, to submit questions and ideas for future topics and speakers, please direct all correspondence to the CFSPCOCACall email address. More information about the CDC CF program is also available at the CDC CFS website. Both of the links for the email address are listed at the bottom of the communications you received regarding today's call, and they are also on the CDC website. Thank you again, everybody, for your participation, and we look forward to having you join us again at our next call.
And thank you, Dr. Gudrun Lange.
Thank you. Bye-bye.
Bye.
This now concludes today's conference. All lines may disconnect at this time.